So the next problem we're going to talk about is retinopathy of prematurity, and it has to do with what happens with the preterm infant's eyes. It's related to gestational age and birth weight. It's rare in babies that are born birth weights greater than 2,000 grams, but basically you're going to see basically what happens is the preterm baby, when they're born, their eyes are not fully developed. The vessels in their eyes are not fully developed. And so the blood vessels stop growing at birth and they get a different type of vessel growth, and the normal vessel growth ceases. That, coupled with high concentration of oxygen, damages the small capillaries in the eyes, and they can develop a type of blindness. A good example of this is Stevie Wonder. When he was born, they didn't know that high concentrations and high pressures of oxygen could cause damage to a preterm baby's eyes. But babies that are on high concentration of O2 and high pressures of O2 and vent dependent, etc., have an increased risk for this developing. So they'll have what is progressive scar tissue and retinal detachment. And it's caused by prematurity, the fragile retinal vessels, and the fluctuating oxygen administration that leads to rapid vasodilation and vasoconstriction. And it is problematic, and it's something that we try to prevent. The next high-risk topic that I want to talk to you about is Meconium aspiration syndrome. This is an increased risk for babies who are post-dates or babies who are stressed in utero. And we talked about, a baby who, when they experience fight or flight in utero, the fight or flight response, one of the things that happens is their sphincters relax and they release meconium. And so if they are in meconium stained amniotic fluid, they have an increased risk of developing this. But what you'll see is a baby who aspirates meconium. They may have meconium stained fluid in their mouth, in their nose, in their lower respiratory tract, such as their trachea, and it can actually go into their lungs. So in utero, a sudden gasp of taking amniotic fluid in surges through their mouth, it makes its way into their mouth and into their lower airway, and it becomes a significant problem after delivery. They've aspirated meconium into the tracheobronchial tree, and it causes air to be trapped in their airway when they start breathing, and it causes overdistension of the alveoli, and the alveoli can actually rupture. We do try to prevent meconium aspiration. You may see a couple of approaches to this. Typically, they try to really suction the baby out at delivery, but some physicians may, as soon as the baby's head is delivered, they would suction the mouth and the throat. This is really no longer supported by research, because what was happening is they were taking too long to suction out the baby, to deliver the baby. But some doctors still do some suctioning. If they have thick meconium after birth, they'll look, is the baby crying or not crying. If they're crying, they're going to suction they're going to suction their mouth and out with a bulb syringe. If they're not crying, they may do some respiratory support. They may stick in an ET tube to see if we have meconium below the vocal cords and suction. It just really depends. Your nursing interventions are to maintain adequate oxygenation and ventilation support, regulate the baby's temperature. We're going to try to keep them warm. You're going to administer IV fluids accurately and carefully. We're going to assess for hypoglycemia. They may give the baby some antibiotics and watch their caloric intake. However, if the baby continues to have respiratory issues in transition, they may have to have other measures, such as they may have to be ventilated, they may have to have nitric acid support or nitric acid therapy or ECMO therapy. So this is a baby who is obviously meconium stained being delivered, and the doctor is just suctioning the baby's mouth before the rest of the baby is born. but they can do other approaches as well, and that they're intubating the baby, and because this baby had transitional issues due to meconium aspiration syndrome. When you look at the pathology, meconium in the lower airway it's almost like dumping chemical lye in the baby's lungs. It's not that it causes massive burning, but it causes a lot of inflammation and edema, and it causes the release of histamines. In addition, surfactant doesn't work well. They have direct toxicity by meconium particles. It causes pulmonary vasoconstriction, and it causes the alveoli, because surfactant doesn't work well, the alveoli become stiff, and they have airway trapping, which you learned about in 1601 when you talked about COPD, but they'll have airway obstruction. And what the baby can develop, kind of what you learned in 1601, they can develop a barreled chest, which you see in this picture of this baby who has meconium aspiration syndrome. So they may intubate the baby. They may try nitric acid therapy. Basically what nitric acid therapy does is it causes the alveoli and the blood vessels in the lungs that are not impacted by the meconium to dilate. So those alveoli and the blood vessels that are surrounding them can take in more oxygen. So it's kind of like a bronchodilator, if you will. It allows more oxygenation to occur and lessens the incidence of chronic lung disease. However, I think of it as a vasodilator, but sometimes that's enough for the baby and the baby can be fine. Some babies, even with nitric acid, they don't show improvement, so what they may need to do is put the baby on ECMO. So what ECMO is it's basically a heart and lung machine. It's a bypass machine. The baby's lungs will heal given enough time, but you basically can't say to the baby's body, take some time off, stop breathing, let the lungs heal, and then come back in a couple of days and be okay. You need lungs for a metabolic to support life. So putting the baby on an ECMO machine allows the blood to be diverted from the baby's body. The blood is oxygenated, it's warmed, and it's returned back to the baby's body, to the aorta, to allow a bypass of the lungs, to allow the baby's lungs time to heal. It's very similar to a dialysis. They're going to have a major catheter placed, and it's going to, the tube is going to enter down through the vena cava to the heart. It's going to be threaded to the heart, what I want to kind of say to you, to the right atrium. This is a very intimidating picture to parents and their kid who's receiving ECMO. The baby is very, very ill. And so you have to have very specialized, highly trained nurses in the NICU environment that are going to administer care for a baby receiving ECMO. And this can be scary for parents because they don't understand what's happening and what all of these different machines are doing. And it's even a little bit more scarier because they're told this baby is very sick and they have to be separated from the other babies in the NICU environment. This is my nephew who had to have ECMO, and I don't show this picture to you just to show you a picture of my nephew, but I wanted to show you a close-up of the tube, and I couldn't find pictures to support what I'm saying to you. But you have two tubes here that run to the baby, and you can see the darker tube and they both contain blood. The one that is darker is taking the unoxygenated blood away from his body to the ECMO machine, where it's going to be oxygenated and it's going to be warmed. And then this kind of lighter red tube is bringing the oxygenated blood back. You will notice how edematous he is, and that's one of the problems with high-risk babies is maintaining fluid balance. They can become hypovolemic or they can become dehydrated easily. It's a fine tightrope that you're walking. My nephew is fine. He's fine. He likes to show people the scar on his neck. He's good. But I showed this because it's kind of scary for parents who don't understand what's going to happen. And here I am, an OB nurse who understands this and trying to help my sister and my brother-in-law understand something that's very technical, and they're non-medical people. My sister is a social worker. This was a lot for them to take in. The next high-risk condition I want to talk to you about is NEC, which stands for Necrotizing enterocolitis. This is a disorder of inflammation and ischemia and necrosis of the intestinal walls. It's a problem that happens in preterm babies. There's several theories that involve looking at the perfusion of the baby's gut that can lead to the ischemia, bacteria, and necrosis, but it's a progressive disorder and it has an increased mortality rate of 15 to 30%, especially in your very early babies. But basically what you have happen is, when we talked about babies don't have the proteins necessary for metabolism when they're born early, and we can try to start to feed them, but they develop intestinal ischemia, massive inflammation, and bacterial colonization of the intestines, and areas become necrotic. So when you look at this pathophysiology, they have to look at the type of feeding the baby's getting, the tonicity of the feeding. Is it hypertonic? Are we feeding them too much? Are there issues that are causing hypoxia and ischemia to blood flow to the mucosal lining of the intestines? Did mom recently abuse cocaine? Is she breastfeeding? If she's breastfeeding, are there issues such as immunoglobulin issues? There's several issues that have to be assessed, but basically we're going to try to prevent this, and if they do, we're going to try to do early intervention to prevent severity and obviously morbidity and mortality. Some of the symptoms that this is developing, you can see abdominal distension, feeding intolerance. The baby will have emesis with feedings or after feedings. You can, in some babies, have frank bleeding from the rectum and diarrhea. When they do a KUB or look at radiographical studies of the baby, they're going to see x-rays are going to show loops of bowel. And this is a baby that has this, and you can see the distension. The things that make you concerned is the dull, dusky color, distended abdomen. This baby also had symptoms of sepsis, temperature instability, poor perfusion, large residual bloody stools, hypoactive or absent bowel sounds, and abdominal tenderness. So this is what you see on x-ray. You can see the loops of bowel that are showing this problem. So they're going to do a couple approaches. One, they may try gastric decompression, have the baby NPO, allow the bowel chance to rest. If this continues and that the allowing the gut to rest does not help and this necrosis continues, they may have to resection part of the bowel. But we're going to do a collaborative approach. They're going to stop the feedings. They're going to give the babies antibiotics. They're going to put an NG tube and give gastric decompression. They'll do parenteral nutrition and make sure the baby stays hydrated. I want to end with gastroschisis. And this is where a baby is born with the intestines outside of the abdominal wall. This can happen to preterm babies or term babies. And the problem is the intestines have direct exposure to the amniotic fluid, so the intestines become thickened, as well as because the baby did not have the intestines in the abdominal cavity, the baby has to they have to stretch the skin over time to lower the intestines back into the baby's body, allow some of the edema in the baby's intestines to heal or to decrease, and then lower the baby's intestines back into the baby's body. And that's what you're seeing here. They keep the intestines in a sterile sac, and they keep it with moist gauze, and over time they lower the intestines into the baby's body, and the baby's abdominal cavity will accommodate the intestines over time. It just takes time for this to occur, and then when they get them lowered in over time, they will eventually close up the abdominal wall. So in looking at your high-risk newborn information, this is kind of your some of your major interventions, despite the different conditions that we talked about. all the babies, you're going to look at thermoregulation, you're going to look at fluid and food needs, you're going to look at temperature regulation, respiratory, and supporting their transition from intrauterine life to external uterine life. This concludes our lecture for the high-risk newborn.